Chronic kidney disease, or CKD, is a progressive disorder that disrupts the body's internal balance. Among its many complications, phosphate imbalance plays a central, yet often under-recognized role. Phosphorus is one of the most abundant minerals in the body. It is a key component of cell structure, energy stores, and signaling pathways governing numerous cellular functions. Most of it is stored in bones, while smaller amounts are found in soft tissues. Only a very small fraction circulates in the blood, yet this fraction is tightly regulated and critically important for maintaining physiological stability. Under normal conditions, phosphate levels are maintained within a narrow range through coordinated interactions between the kidneys, bones, and hormones such as fibroblast growth factor 23, parathyroid hormone, and vitamin D, which regulate phosphate absorption, storage, and excretion. In the early stages of CKD, adaptive mechanisms increase the levels of FGF23 and PTH to maintain phosphate balance. However, as kidney function declines, phosphate excretion becomes insufficient. Continued dietary intake leads to phosphate retention and ultimately hyperphosphatemia. Elevated phosphate is not just a biochemical abnormality. It actively drives vascular calcification, causing calcium phosphate deposits to accumulate in blood vessels, leading to arterial stiffness and increased cardiovascular risk. Phosphate overload also promotes oxidative stress and chronic inflammation, contributing to multi-organ damage. In the heart, this is associated with structural remodeling, including left ventricular hypertrophy and impaired function. Disrupted phosphate metabolism further leads to mineral and bone disorders, resulting in reduced bone strength and increased fracture risk. Managing hyperphosphatemia remains difficult. Dialysis alone is insufficient for removing the daily phosphate load. Dietary restriction is challenging and may increase the risk of malnutrition and affect quality of life. Phosphate binders are widely used but often entail a high pill burden and may cause gastrointestinal side effects, leading to poor adherence. To address these limitations, new therapies targeting intestinal phosphate absorption have been developed. One such agent, tenapanor, works through a novel mechanism by inhibiting sodium-hydrogen exchanger 3 in the intestine. This reduces paracellular phosphate absorption, offering an alternative approach that does not rely on binding phosphate in the gut. However, despite these advances, convincing evidence that lowering phosphate improves long-term clinical outcomes remains limited, suggesting that phosphate toxicity may involve more complex regulatory and sensing mechanisms. Ultimately, phosphate is not just a marker of CKD, but a key driver of its complications. The derangement of phosphate balance begins in the early stages of CKD and worsens with the progression of kidney disease. A deeper understanding of phosphate regulation may be essential for developing more effective therapies, earlier intervention of regulatory mechanisms, and improving patient outcomes.